CNA Developmental Disabilities. Welcome to the quiz. Question 1. A patient with metabolic acidosis e.g., diabetic ketoacidosis exhibits Kussmaul respirations. What is the specific pattern and the intended physiological compensation? Option A. Shallow, rapid breaths to decrease POW and increase acidity. Option B. Deep, rapid breaths hyperventilation to blow off CO of volatile acid and raise blood pH. Option C. Periods of apnea followed by crescendo-decrescendo breathing Cheyne-Stokes to increase POCO. Option D. Prolonged inspiratory pauses to increase alveolar recruitment. The answer is B. Metabolic acidosis is a primary decrease in blood pH due to an increase in non-carbonic acids like keto acids or lactic acid. The BOTUS primary respiratory compensation for this is to lower the POCO. How? By increasing alveolar ventilation. Kussmaul respirations are a specific pattern of deep large tidal volume and rapid increased rate breathing. The depth is particularly characteristic. This hyperventilation serves to blow off carbon dioxide CO. Since CO in solution forms carbonic acid HCO, removing CO effectively removes acid from the blood. This raises the blood pH back toward normal, partially compensating for the metabolic acidosis. The deep breaths are more effective at removing CO than shallow, rapid breaths. Option A is incorrect. Shallow, rapid breaths are less effective at gas exchange and would not effectively lower POCO. Option C, Cheyne-Stokes breathing, is associated with heart failure or neurological disorders, not with straightforward metabolic acidosis. Option D, prolonged inspiratory pauses, is not a typical compensatory pattern for acidosis. Question 2. Pulmonary function is dependent on compliance and airway resistance. Which condition primarily decreases lung compliance, making it stiff and increasing the work of breathing? Option A, asthma, due to bronchospasm and mucus plugs. Option B, emphysema, due to destruction of elastic fibers. Option C, interstitial lung disease e.g., pulmonary fibrosis, due to collagen deposition. Option D, chronic bronchitis, due to airway inflammation and hypertrophy. The answer is C. Lung compliance refers to how easily the lungs expand when pressure is applied. High compliance means they stretch easily. Low compliance means they are stiff and hard to inflate. Interstitial lung diseases ILDs, such as idiopathic pulmonary fibrosis, are classic restrictive diseases that primarily decrease lung compliance. The pathology involves inflammation and scarring fibrosis of the lung interstitium tissue between the alveoli. This scarring deposits stiff collagen, making the lung tissue less elastic and more resistant to stretching. Patients have to work much harder to inhale a normal volume of air. Option A, asthma, and Option D, chronic bronchitis, are obstructive diseases. Their primary problem is increased airway resistance, not reduced lung compliance. In fact, in asthma, lung compliance may be normal or even increased during an attack due to hyperinflation. Option B, emphysema, actually increases lung compliance because the destruction of alveolar walls and elastic fibers makes the lungs too floppy and easy to overinflate, leading to air trapping. Question 3. The partial pressure of oxygen in inspired air PO at sea level is approximately 160 millimeters of mercury. What is the primary reason it drops to about 100 millimeters of mercury in the alveoli PO? Option A, consumption of O by the alveolar epithelial cells. Option B, dilution with water vapor and the mixing with residual CO-rich air from the previous breath. Option C, rapid diffusion of O into the blood before equilibrium is reached. Option D, the physiological shunt from bronchial circulation. The answer is B. The air we breathe in inspired air is dry and contains about 21 oxygen. At sea level barometric pressure 760 millimeters of mercury, the partial pressure of inspired oxygen PO is 0.21760 millimeters of mercury. By the time this air reaches the alveoli, where gas exchange occurs, its oxygen partial pressure PO is only about 100 millimeters of mercury. This drop is not mainly because oxygen has been absorbed into the blood yet that happens after the air is in the alveoli. The primary reasons for the drop are 1. Humidification. The air becomes fully saturated with water vapor in the upper airways. Water vapor exerts a pressure of 47 millimeters of mercury at body temperature, which dilutes all other gases. 2. Mixing with residual air. The incoming fresh air mixes with the old air already in the alveoli from the previous breath, the functional residual capacity, FRC. This residual air has a lower O and higher CO content. This mixing further reduces the O concentration. The actual diffusion of O into the blood happens very quickly once fresh air reaches the alveoli and is not the main cause of the overall drop from 160 to 100 millimeters of mercury. Option A is minor. Alveolar cells consume very little O directly. Option C is incorrect because diffusion is rapid and equilibrium is reached. The PO of 100 millimeters of mercury is the equilibrium value. Option D, the bronchial shunt, is a small effect. Question 4. The maximum volume of air that can be exhaled after a maximal inspiration is called the vital capacity VC. Which of the following lung volumes cannot be measured directly by simple spirometry? Option A, tidal volume TV. Option B, inspiratory reserve volume IRV. Option C, expiratory reserve volume ERV. Option D, residual volume RV. It requires body plethysmography or gas dilution techniques. The answer is D. Simple spirometry involves a person breathing into a mouthpiece, and it can only measure volumes of air that can be exhaled from the lungs. Vital capacity VC is the max exhalation after a max inhalation. Tidal volume TV, inspiratory reserve volume IRV, expiratory reserve volume ERV, and forced vital capacity FVC are all volumes that involve movement of air in or out and can be measured with a spirometer. However, the residual volume RV is the volume of air that remains in the lungs after a maximal exhalation. This air cannot be exhaled, so it cannot be measured by simple spirometry. To measure RV and therefore total lung capacity, TLC-VC-RV, special techniques are needed. The two main methods are 1. Helium dilution or nitrogen washout. The patient breathes from a closed system with a known concentration of an inert gas like helium. By measuring how much the gas is diluted by the air already in the lungs, RV can be calculated. 2. Body plethysmography. The patient sits in an airtight box and pants against a closed shutter. Changes in pressure and volume allow calculation of thoracic gas volume, which includes RV. Options A, B, and C are all directly measurable with spirometry. Question 5. The primary drive for breathing in a healthy individual at sea level is the level of arterial. Option A, PACO carbon dioxide tension, detected by central chemoreceptors. Option B, POW oxygen tension, detected by peripheral chemoreceptors. Option C, pH, detected directly by medullary neurons. Option D, bicarbonate level, detected by renal tubules. The answer is A. Under normal, resting conditions at sea level, the most important factor controlling the rate and depth of breathing is the arterial partial pressure of carbon dioxide PACO. This is because CO levels are tightly linked to blood pH through the carbonic acid reaction. An increase in PACO hypercapnia leads to an increase in hydrogen ion concentration acidosis in the cerebrospinal fluid CSF, which powerfully stimulates the central chemoreceptors on the ventral surface of the medulla oblongata. These receptors signal the respiratory centers to increase ventilation, which blows off excess CO, returning PACO and pH to normal. This is a very sensitive system. Option B, POW, is monitored by peripheral chemoreceptors, carotid and aortic bodies, but these are not the primary drive in healthy individuals. They become significant drivers only when POW falls below about 60 millimeters of mercury, severe hypoxia. Option C is partially correct but imprecise. It is specifically the H in the CSF caused by CO. not blood pH directly, that stimulates the central chemoreceptors. Option D, bicarbonate, is important for acid-base balance and renal compensation, but it is not the direct stimulus for breathing. Question 6. In a patient with a tension pneumothorax, the collapse of the lung is accompanied by a shift of the mediastinum to the opposite side. What is the immediate life-threatening consequence of this shift? Option A, compression of the contralateral lung, impairing ventilation. Option B, kinking of the great vessels, impairing venous return to the heart and decreasing cardiac output. Option C, both A and B are correct and represent the critical pathophysiology. Option D, rupture of the parietal pleura, leading to subcutaneous emphysema. The answer is C. A tension pneumothorax is a medical emergency. It occurs when a one-way valve leak from the lung or chest wall allows air to enter the pleural space on inspiration, but prevents it from escaping on expiration. Pressure builds up in that hemithorax. This has two catastrophic effects. One, lung collapse. The increasing positive pressure collapses the lung on the affected side. 2, mediastinal shift. The high pressure pushes the mediastinum, the central compartment containing the heart and great vessels, toward the opposite side. This shift compresses and kinks the superior and inferior vena cava, drastically reducing the amount of blood returning to the heart preload. With less blood to pump, cardiac output plummets, leading to obstructive shock, which is rapidly fatal if not treated. The shift also compresses the contralateral good lung, further impairing ventilation, but the immediate life threat is the cardiovascular collapse from impaired venous return. Therefore, both A and B are correct and together define the critical pathophysiology. Option D, subcutaneous emphysema, air under the skin, is a common finding but is not itself immediately life-threatening. Great job! Don't forget to subscribe. Bye!